So now we move on to another nerve which creates mischief. That's the third nerve palsy. And there are different strokes in this. The third nerve is a big challenge. I have no financial disclosures again. And as you can see, third nerve supplies all the different muscles that are there in the orbit except for lateral rectus and superior oblique. So it's a big problem. So one is that you have to be careful that you may or may not require surgery. Ischemic third nerve palsies which have a pupil sparing, of course you should wait, and you may after a month, if it is not recovering, give Botox. But otherwise just give time and many of these will recover. And as we have seen, like this individual, ischemic third nerve palsy, you see that the pupil sparing is there in the right eye, and he is an elderly person because of which there is a morbidity. And we did a study and we found that many of the people have diabetes, hypertension, which is the most common, and these can have a mononeuropathy, which will usually recover in 6 weeks to 3 months time. But if they don't, or if there is some other cause, then we have to do a surgical management, and you wait for 6 to 9 or 12 months. Now here is a case 1 in which you can see a large angle exotropia which is there, and he happened to be a doctor, by the way. And what we wanted to do is that we wanted to control also the abduction. We didn't want to lose abduction. So what I did in this LR recession of 24 millimeters. Now here, remember, LRs can be having a long room for recession. If you do small amounts of recession, you will have a problem still. So LRs, you may go up as per the FDT. And in this case, I did 24 millimeters of LR recession and an MR plication of 8 mm. And you see here that the eyes are in the primary position. There is a comfortable abduction also still there. So we are not losing the lateral rectus altogether. So many a times I get cases of operated which then you have to redo on the LR. So this is one take home. Case 2, split LR transposition. A new addition to our armamentarium is NT-SLR, the nasal transposition of split lateral rectus. Okay, a very good procedure. Whenever the FDT for LR is not very, very tight. It mildly tight, you can still do it, but not very tight. If it is very tight, then there will be a problem doing itself and also having other problems. This is another case in which the NT-SLR was done, but there was a vertical deviation also which was very striking. So in such cases, what can you do otherwise? That you can operate on the other contralateral side, vertical recti, to give a correction for the vertical diplopia which is there along with. Now third nerve palsy, exo with hypertropia. Now this sometimes, can we do a nasal transposition of lateral rectus without splitting? Yes. So that's another thing which can be done. You can, lateral rectus can be shifted without splitting inferiorly to correct the forces of exo, as well as also bring the force little downwards. So if there is an hypertropia like in this boy, and I did a nasal transposition of the lateral rectus, full tendon transferred inferiorly, and you can see here that the eyes have also got corrected for the vertical offshoot by just one muscle. So one muscle shifting can do the trick. You may have to put a Foster suture in order to get the lateral rectus little close to the medial rectus. Very tight lateral rectus, what do? You can do a periosteal anchoring of the lateral rectus. So here it is a lateral rectus which is very, very tight. You want to take away altogether its force, then anchoring of that can be done, which was demonstrated by Velez in JPOS 2004. And this is a good procedure which can be used selectively. But very exo of 90 to 100 prisms, what do? After the lateral rectus has been stripped of all its function, still the eye is exo. That case you can do a periosteal anchoring of the globe medially. So this is another procedure which can be done in these cases, and we have talked about doing through the DCR skin approach as well as the pre-caruncular or retrocaruncular approach. Aberrant regeneration, what do? If you have an aberrant regeneration of the lid, then what can we do? Sometimes, like in this case, what do you see here? In the primary position, the eyes are ortho. The only problem here is with the lid. So this case came with the problem of lid. You have to counsel them that, look here, I am not required. I might be requiring an oculoplasty surgeon, but he also may not dare to do in the presence of a third nerve palsy anything, and only a suspension sometimes, or maybe just a spectacle with a crutch glass may be given. So here you need to just counsel. But sometimes we find that there is a correction by the contralateral eye being operated, like in this case, The left eye is third nerve palsy exo. I operated on the right eye, the recess resect with the fixation duress approach, and you find here that these also can be a very good approach to correct. Like this case, you see here the eyes are ortho in primary position. The lid which was having ptosis has also got corrected because of the fixation duress getting the innervation to the LPS. What do you do in cases of acquired partial third nerve if there is an inferior division alone which has been involved? Now you find these cases having exo with an hypertropia. So one possibility is, of course, you can shift the lateral rectus full width nasally, or what else you can do is an inverse nap procedure. Now what we mean by inverse nap here is modified inverse nap. Now what I mean here is that you want to have a downward force as well as weaken the lateral rectus. So if you do a lateral rectus weakening and then shift it, it's not going to work as good, because you are asking the lateral rectus to work as well as weaken it. That is something which is a paradox. So what I do is lateral rectus is shifted as it is. The exo is corrected by the medial rectus, which is resected and shifted. So that is a modified inverse snap. That you resect the medial rectus, you strengthen the medial rectus, which will also give you a downward force as well as give you an adduction force, and the lateral rectus is weakened. Unless the FDT is still tight, you don't want to recess the LR. So that is something which can be done, like in this case, this girl who was an aspirant medical student, and she's very happy with this, that she's having a correction. Sometimes you have a lateral incompetence in the other eye, and in such cases I have operated on the other eye lateral rectus, a Scott procedure. That means you want to weaken. Why? If you see here in the gazes, 8 prism basin, there is a 16 prism basin in the primary position and 35 prism basin in the adduction. So what do you do? How can you improve it further? You can, if you weaken the lateral rectus such a way that you have more of weakening on the abduction, you can do a Scott procedure on the lateral rectus, because Farden doesn't work well on the lateral rectus. So what you do, alternative to Farden is a Scott procedure on the lateral rectus. It works very good, and you can try this doing it. So here, this is what we did in this lady, and we found that the abduction was more neatly controlled, and this is published in JPOS. A re-surgery, sometimes these cases come up because the lateral rectus has not been recessed enough. So you have to explore it, do an LR recession. So I happen to do 25 millimeters of re-recession then finally, and with an IR belly transfer to the medial rectus. So just half of Nishida or belly transfer of the inferior rectus alone was done in this case, and that has got corrected. Again, he was a medical doctor, and we had to be a little more concerned that he retains his binocular vision. So important points to remember in third nerve palsy is deviation in the primary position and other gazes have to be taken into account. Fixing eye is the target deviation. Look for the incompetence. The realistic goal has to be told to the patient. You may not be able to correct all the 9 gazes. We try to correct the primary and maybe little bit of hypo. That is what may be the only thing which may be correctable. And you do the FDT of the LR, supramaximal recessions, periosteal fixation or split LR to MR, these are the options, or also a contralateral muscle surgery. Either the horizontal recti for the LPS action, or sometimes the vertical recti on the opposite muscles can be done. So you